All right, hello everybody. My name is Ryan,
My name is Chan.
My name is Alec.
and we're here to teach you about a total hip replacement, what it is, the history of it, the precautions and protocols, and the different approaches. So you may be wondering, what is a total hip arthroplasty? A total hip arthroplasty is when the damaged bone and cartilage is removed and replaced with a prosthetic. This approach is often used for older adults who have arthritis in the femoroacetabular joint. Please enjoy this short video on how the procedure is done.
Total hip arthroplasty, also called total hip replacement, begins with an incision to allow access to the bones of the hip joint. The next step is to remove damaged cartilage and bone from the acetabulum, the cup-shaped hollow in the pelvic bone. This damage results from the bones rubbing directly against each other when protective cartilage wears away. A tool called a reamer is used to prepare the acetabulum to receive the socket portion of the hip replacement. This metal and plastic combination is called the acetabular component and is fitted into the newly reamed bone surface. The outer metal part of this component, sometimes called a cup, fits directly into the socket. The inner plastic portion has a hollow to hold the replacement for the ball-shaped bone at the top of the thigh bone or femur. The outer metal part is rough to help bone grow into its surface over time to lock the artificial socket in place. The next step is removing the ball-shaped head of the femur or thigh bone and preparing the femur for placement of the stem portion of the component. A metal ball is attached to the end of the stem and fits into the artificial socket in the hip bone. Together, these components replace the natural ball and socket joint. During and after surgery, the surgeon verifies the correct fit and range of motion of the hip replacement components. By mimicking the anatomy and functioning of the natural hip joint, hip replacement can reduce pain and permit a return to many activities.
Now that we know how the procedure is done, let's look at the prosthesis used in it. It consists of four major components: the acetabular component, the plastic liner, the femoral head, and the femoral stem. The acetabular component consists of a metal cup, which is inserted into the shaved-down acetabulum with a plastic liner placed inside. The new head of the femur is created by inserting a femoral stem into the bone where it is capped off by a metal head. The acetabular component is rough and bumpy, so bone can grow into the grooves. Now let's get a little bit into the early history of total hip replacements. The first recorded attempt was in 1891 in Germany by Professor Gluck. He presented his findings at the 10th International Medical Conference, where he thought that ivory was best suited to replace femoral heads in patients whose hips were destroyed by tuberculosis. Surgeons later experimented with various tissues and with various tissue placement between hip surface and an arthritic hip. The first mold arthroplasty was created by Dr. Mary Smith Peterson, a hollow hemisphere made of glass that would cover the femoral head. The glass proved fragile and would break under certain circumstances. For this, stainless steel was the preferred method. In 1953, Dr. George McKee was the first to regularly use a metal prosthesis. He used a modified Thompson stem and a cobalt socket as the new acetabulum. This method soon fell out of favor, though, in the 1970s due to high failure rates. During this time, the father of modern total hip arthroplasties would arise, Sir John Clarney. He used a low-friction arthroplasty consisting of a metal femoral stem, a polyethylene acetabular component, and acrylic bone cement borrowed from dentistry. Currently, there are over 75,000 replacements each year. The average age of people getting their hips replaced has decreased, which brings to light the magnified issues of replacements failing due to bearing wear and tear.
Okay, let's talk about the three types of approaches that we're going to be talking about. So firstly, we have the posterior approach. Secondly, we have the anterolateral approach. And lastly is the anterior approach. Let's firstly talk about the posterior approach for total hip replacement. The posterior approach requires the splitting of the gluteus maximus to access the hip joint posteriorly, as you can see right here, splitting of the gluteus maximus. This actually allows for excellent exposure of the acetabulum and the femur. It's what you see right here. There's really good exposure right there. However, the downside of this approach is that it has a slightly higher risk of dislocation compared to the anterior and lateral approach. Now let's talk about the lateral approach. In this approach, there is an incision from the lateral side of the body where the hip is. During the incision, it requires the splitting of the gluteus medius, as you can see right here, in order to access the hip anterolaterally. The concerns with this approach is the risk of superior gluteal nerve injury, which can lead to mobility issues and also pain. Another concern is the risk of heterotopic ossification, which is the formation of bone in the soft tissues where bone normally do not exist. Since this approach is cutting into the gluteus medius is a hip abductor, so it can lead to impaired hip abduction function. Lastly, let's talk about the direct anterior approach. This is the most popular and favorable approach due to the earlier functional recovery time, lower risk for dislocation, and shorter hospital stay compared to the other two approaches. However, the operating time for this approach is a little longer than the other approaches. The incision for this approach is unique as they make an incision from the anterior side of the body and gets to the hip joint between the sartorius and the tensor fasciae latae muscles right there.
Phase 4 is the most advanced phase, which typically leads to medical discharge. The goal in this phase is to work with the PT and MD to create a plan to return to regular activity. A patient is ready for discharge when they reach about 80% of their functional level before surgery. They also have to demonstrate ability to simulate specific functional movement like walking normally without any assistive device. The criteria for discharge from PT is less rigorous for those now returning to sport. Phase 1 of the rehab protocol is directly after the operation. The main goals are to control pain and swelling, begin restoring ranges of motion, and establish lower extremity activation. Some exercises that are included in this phase are ankle pumps and quad sets. Here's a video demonstrating some of these exercises.
Down, plantar flexion, back up, just like that. Okay, let's do nice and easy. Let's do 3-second holds. Rest. Good job.
Phase 2, the goals are to restore leg muscle strength and to initiate proprioceptive and endurance training. The exercises in this phase can include standing hip flexion, weight shifting, and single leg balance. Here are some examples that are used in this phase.
Looks like a good height for you. On. All right. I'm gonna have you on here for 10 minutes. Just kind of get the blood flowing, get the hips moving a little bit.
Lift your leg until you feel a stretch on the back of your leg. You're gonna hold that for 30 seconds, and you're gonna do that for 3 sets.
How's it feeling?
Feeling pretty good. Feel a little weak, but we're working on it.
In phase 3, we really start seeing the increase in strength. The goals are to restore the patient's normal leg strength and baseline functional activities. Range of motion and stretching continues from the previous phases, but the resistance is increasing the strengthening program. A strengthening exercise that can be used in this phase is the leg press. Here are a couple of examples of the exercises used in this phase.
You ready for this? Yes, sir. Got it. All right, let's go. Nice. How's it feeling?
Feels pretty good. I think we could put on some more weight.
Some more weight.
Yeah.
Don't get too strong for us.
Getting pretty strong, man.
Good stuff, good stuff. Phase 4 is the most advanced phase, which typically leads to medical discharge. The goal in this phase is to work with the PT and MD to create a plan to return to regular activity. A patient is ready for discharge when they reach about 80% of their functional level before surgery. They also have to demonstrate ability to simulate specific functional movement like walking normally without any assistive device. The criteria for discharge from PT is less rigorous for those not returning to sport.